First thing I'm going to do is ask Jesse to stand up on his feet and do a little bit of walking. So if we can get you to walk forwards and backwards, Jesse. As with any other lower limb joint, it's important to have a look at his gait, to have a look whether he's having any difficulty walking, and to see whether there's any real problems with that. You just find a little bit of space over there again, Jess. One of the things I like to do with hip pain and with most lower limb joints is to do a hop test. So I'd like you to stand on one foot, hop up and down. Does that create any pain or problems? So if the athlete has pain with that, then I'm thinking, is this potentially a stress fracture? Have they had an acute injury? Is this something more significant? From this point, I'm going to get them to lie down flat on the bed, and the rest of my examination is going to be done with them lying down. So ideally, the patient would be in their underwear, so we can have a good inspection around the hip and groin. So I think it's important to be able to see the low abdomen and the structures around the hip and groin. Palpation is also important, and we need to think about what the likely diagnoses are going to be. If we have an adolescent athlete who's come with an acute onset of pain, we might be thinking about a traction apophysitis, and we need to palpate around the major tendon attachments, so the ASIS, where the sartorius muscle attaches, and the anterior inferior iliac spine, where the rectus femoris attaches. So palpating in there is important. Also palpating on the pubic symphysis is important, and that's generally a tender place. Between the ASIS and the pubic symphysis, we can palpate over the hip joint. And as you'll see in a minute, it's also important to palpate the adductors and the low abdomen, low rectus, and conjoint tendons. So palpation is definitely important. What I like to do next is to move the hip joint around. So hip movements are a fairly non-specific test, but they can be quite useful at identifying hip joint pathology, so femoroacetabular impingement and labral tears. So we'll get the athlete to flex their hip up passively. Any pain or problems with that, and then I'll add a little bit of extra pressure there. Any pain or problems with that. So that's a relatively insensitive test, but patients with hip pain rarely have no pain with that movement. In 90 degrees of hip flexion, I'll then assess internal rotation, looking for any restriction in range of motion or any pain with that. And again, patients with hip joint pathology, it's rare for them not to have pain with that movement. It's a very sensitive test. I'll also test external rotation. That's generally less provocative. But if we're thinking again about an adolescent with a SUFI, their hip will flex and externally rotate, so that may be an important clinical sign. And then I do a quadrant test, which involves flexion, internal rotation, and adduction, and that again is very provocative for patients with hip joint pathology. I also think passively adducting the hip and adding internal rotation is provocative, and then as you take it into external rotation, less provocative. Another test that's described for hip joint pain and for sacroiliac joint pain is the Faber test. So we ask the athlete to put their heel on the knee on the contralateral side and let their hip drop out into external rotation. So is that stiff? Is that painful? And we add a little bit of extra pressure. So if an athlete has lots of pain and it reproduces their presenting pain, so the symptom that they've come with, I'm starting to think this could be a hip joint problem.